Hi, my name is Dhruv Khetarpal. I'm a fourth-year medical student at UTHSC College of Medicine. Today I'm going to be presenting a patient case about new onset atrial fibrillation triggered by Legionella pneumonia. So this is my poster, and I'll dive into an introduction on the topic. Atrial fibrillation typically arises from ectopic foci, i.e. abnormal electrophysiologic alterations in the atrial myocardium. It can be triggered by a variety of causes, including other illnesses such as pneumonia, infection and inflammation of the heart, pulmonary embolism, hyperthyroidism, or simply having structural heart disease. When examining pneumonia as a cause, up to 7.6% of patients with community-acquired pneumonia can develop atrial fibrillation. In this case report, a case is presented detailing the story of an elderly immunocompromised man with atypical Legionella pneumonia who arrived with new onset atrial fibrillation. The prevalence of involvement of L. pneumophila in relatively severe respiratory infections has been shown to be about 2.7%. Legionnaire's disease can be a serious disease with mortality ranging between 5 to 15%. Atrial fibrillation presented an added complication to this course that likely increased morbidity and mortality risk. Go into a description of the case now. So, on a Monday morning in downtown Nashville, a 75-year-old man presented to the ER with a 3-day history of severe shortness of breath. He described a new cough in the past few days and loose stools with some lower extremity edema and generalized fatigue. He was recently hospitalized about a month prior, during which he was diagnosed with autoimmune hemolytic anemia, started on high-dose prednisone 100 milligrams daily. This particular morning, he went to his PCP, who noted he was hypoxemic, told the patient to go to the ER, where he was afebrile, tachycardic, with a pulse rate between 114 to 127. He was also tachypneic and hypotensive on one measurement at 80 over 49, his blood pressure. Labs were notable for a creatinine of 1.7 from a baseline of zero point 0.8, a hemoglobin of 9.3, and leukocytosis with a white count of 23.5 thousand. Peculiarly, the patient was hyponatremic with a sodium of 130. Chest X-ray displayed both right upper and lower subsegmental consolidation in airspace densities consistent with right-sided pneumonia. His EKG showed an irregular tachycardic rate with no visible P waves consistent with A-Fib, a diagnosis that this patient never had before. For his right-sided pneumonia, he was started on empiric antibiotics consisting of piperacillin-tazobactam and vancomycin for MRSA coverage. For his AFib, the patient was placed on telemetry and given diltiazem doses before a drip was eventually initiated for heart rate control. Anticoagulation with heparin was also begun. Over 4 days, the patient's appearance and breathing continued to deteriorate, and he was moved to the ICU and placed on Vapotherm with increasing oxygen requirements. Rails were heard in both lung fields, more prominently on the right side. On hospital day 6, with neither clinical improvement nor improvement on repeat chest X-ray, the infectious disease team began testing for other organisms, including a urine Legionella antigen test, which was positive. He was starting on levofloxacin at that point and began showing marked improvement. Over the next few days, he was transferred out of the ICU, moved back to 4 liters of oxygen by nasal cannula. When he initially showed oxygenation improvement, he was also taken for cardioversion and returned to sinus rhythm. His rhythm was controlled on amiodarone and metoprolol leading into discharge, and apixaban was prescribed for stroke prophylaxis. Now we'll go into, so this is actually an EKG that was done during his admission, showing AFib, lack of P waves prior to cardioversion. Now we'll go into a discussion of this case. Pneumonia can have many etiologies in the elderly, especially in patients with autoimmune disease and on immunosuppressive medication. Legionnaire's disease was a culprit here and typically presents with pneumonia, hyponatremia, and diarrhea, all of which were present in this patient. However, it can also be associated with rhabdomyolysis and acute renal failure, the latter of which our patient also experienced. Legionella has been associated with myocarditis, pericarditis, and endocarditis. Pneumonia itself can trigger AFib or arrhythmias in general, often seen within 90 days of admission to the hospital. Our patient arrived at the hospital with concurrent new onset AFib and right lung consolidation, raising the possibility of AFib and pneumonia acting in a chicken or the egg scenario. His recent high-dose prednisone may have put him at an increased risk of acquiring atypical pneumonia leading to atrial fibrillation. Regarding diagnosis criteria and treatment decisions, testing for atypical pneumonia was indicated in this patient given the long-term immunosuppression, recent hospitalization, and failure to respond to beta-lactam therapy. Several institutions recommend Legionella testing for any patient hospitalized with pneumonia. Legionella urine antigen testing has a rapid turnaround and is nearly 100% specific test with 70 to 80% sensitivity. The main downside is its ability to only detect L. pneumophila serotype 1. For directed Legionella treatment, levofloxacin or azithromycin are the typical treatments of choice. In developing a treatment plan for A-Fib, context is important as often resolution of the triggering pneumonia can lead to resolution of the A-Fib. Initial treatment for new onset A-Fib with RVR consists of anticoagulation for prevention of stroke, in addition to rate control in the short term with a diltiazem drip in our case. The patient had a CHA2DS2-VASc score of 5, indicating need for long-term anticoagulation. With the patient failing a trial of spontaneous conversion to sinus rhythm, cardioversion was scheduled and done when appropriate, successful for both rhythm and rate control. Long-term management with amiodarone for rhythm control and metoprolol for rate control were initiated. Thank you for listening to this. I think it's a really interesting case, and I'm happy to present it. Thank you so much.